Today my topic is radio frequency ablation in refractory knee and hip osteoarthritis pain and our hospital MSK experience. I have no disclosures or interest to declare. And let's see the guideline. The American Society of Pain and Neuroscience recommends IFA for hip joint pain following diagnostic nerve blocks and targeting the obturator and the femoral nerve branches. However, the comprehensive review noted that the evidence base of hip IFA is small and low quality. And in contrast, the IFA for knee OA has stronger supporting evidence and there are more consistent guideline recommendations. And the NIC guidelines describe that IFA can conducted under fluoroscopy or ultrasound guidance. And the ASPN 25 guidelines say that for both knee and the hip IFA, we should use the pre-procedural diagnostic blocks first. And however, the recommendation statements are general. They just specify about the target nerve, including genicular nerve, obturator, and the femoral nerve, but there are no further specific recommended treatment protocols. So let's move on to the knee joint capsule innovation first and the ablation first. And just like my talking about, you can do fluoro-guided or ultrasound-guided genicular nerve block. And for the fluoro-guided, we focused on the superior medial, superior lateral, and the inferior medial side. And when we use ultrasound guidance, it's at the same location, but we didn't use the bony landmark, but following to see where is the genicular artery, and we will inject infusion around the genicular arteries. So there are, thanks to advanced materials, and we should watch out about the lateral inferior area, and they suggest don't block the lesion over here because it is very near of the common peroneal nerve, and sometimes you will cause the drop foot. And this article is talk about under ultrasound and the fluoro guidance, and there is no significant. The result is similar, and no obvious difference between these two kind of technique, two kind of image guidance. So you can use both technique. And this is another article because I talk about that the inferior lateral area is dangerous, but in this article, they injected the nerve, the inferior lateral genicular nerve under ultrasound below the lateral collateral ligament at around the popliteal groove levels. And they say the nerve block is about 60%, and there is no involvement of the common peroneal nerve, so there will be no motor weakness can be avoided. It can be avoided. And this is the location. You can see where they injected, just below the lateral collateral ligament and around the popliteal groove. And that is the location of inferolateral genicular nerve. And talk about the radio frequency ablation and the radio frequency modulation. They are different. For the ablation, we use the rapid alternating electrical current and generate friction heat to cause the tissue necrosis and the destruction, then of course involving the nerve, so we relieve the pain and burning the painful nerve. But for the IF modulation, we use high frequency short pulse, and there is no continuous high heat, so we can avoid tissue destruction. And it can be used for the mixed motor and the sensory nerve like spine, dorsal root ganglion treatment. And for the bipolar, if we use bipolar technique, and we can generate more large affected inter-tip region can be heating, but the distance between the tips should not no more than 1 centimeter. And then standard IF operation, it will have higher degree up to 18 degrees. So the operation zone is elliptical and some tissue charring will occur. But when we use cool radial operation, it's not a new technique. It can keep the tip cooler around 60 degrees, allow larger and more spherical lesion and cover broader zone. And so the operative zone of cool IF is around 5 times than the traditional IF. And you can see this is the operation zone, and the golden one is the cool IF. So you can see when you operate larger zone, and the cover nerve will be more involved. And this is the final needle classic approach in the knee genicular nerve. And the traditional target location is 2/3 bone shape depth, because that is the nerve location. But in this article, for the superior medial knee pain, and they do the sacrifice of the leg, and there is no found superior medial genicular nerve on the traditional target location in this study. And it is more superficial, more anterior to the location. And for superior lateral knee pain, and they found out actually there are two nerves, the lateral nerve, the deep branch of and the superficial branch, there are two nerves. We can see, so it suggests there are should be two separated approach for both superior medial and the superior lateral genicular nerve. Just like this, you can see there are two locations, the deep branch and the superficial branch on the lateral side. So there are, when I went to American international conference, they suggest a pull back technique for the superior medial and the superior lateral area. First operation is 2/3 bone shape days, and the second operation is 1/3 bone shape days. And this is my case, 60-year-old female with lateral knee pain. And you can see the joint space mild narrowing. But on the MRI, you can see there is the subchondral insufficiency fracture with extensive bone marrow lesion, synovitis, soft tissue, swelling, and you can see angiogenesis under the MR angiography. So I execute 10 embolization, first genicular artery embolization. I see the angiogenesis. I do some embolization, but patient tell me there is no any improvement after the embolization with antibiotics. So I use intraosseous PRP injection in the subchondral bone marrow lesion, and the patient tell me there are still no any improvement after the intraosseous PRP injection. So then I do the genicular nerve block, just like I mentioned before, use ultrasound and the fluoro guidance. I use triamcinolone and mix in Macaine, but also you can mix in lidocaine. And the patient tell me the pain improved a lot immediately, but gradually relapse. And she say, how about the injection? She said, almost no pain now after injection. It has been a long time since I can go work like this, yeah. So I then do the genicular nerve ablation, use bipolar technique for under fluoro guidance. But for the inferior lateral genicular nerve, because I think it is still dangerous, so I used pulse IF because I just do modulation. I don't want to produce drop through. And she is very satisfied, and the pain relief lasting for 8 months. And this is another 54-year-old male. He has received medial meniscus repair, plica resection, and synovectomy. But he complained persistent medial pain, joint pain, even after the surgery for 1 year. And you can see OA change on the X-ray for medial joint space, narrowing, spurs formation, and the various alignment. And there is also some bone marrow lesion, and you can see there are some MR angiogenesis on the MR angiography. So of course I do embolization again first, and he said no any improvement after the embolization. So I do the intraosseous PRP injection again, intraosseous and periligament PRP injection under ultrasound guidance, and I asked him any improvement. He said I feel more painful after your injection. So and then I do the genicular nerve block. So just like I mentioned before, and he said the pain improved, finally improved, first time, yeah. So I do the core IF for genicular nerve ablation. And I also do some injection after I do the core IF ablation. And he said the pain dropped to 1 and no pain relapse. And the patient, he say he is very satisfied of this technique. And then let's move on to the hip joint. There are two vessels you should engage. One is femoral arterial branch, other is obturator arterial branch. And I use core leaf technique, use core IF technique. And one is the target, you should target osseous or acetabulant. And another target is more dangerous, is obturator arterial branch. So I approach it, you should approach it from the ischial tuberosity and go upward to the incisura, the teardrop-like structure. Just like this, you move the needle to the teardrop structure. But you should be careful, there is some muscular and the nerve branch here on the inguinal area. Of course, I do the hip joint nerve block first before I do the operation. So this is my case, and I do some case embolization for hip joint pain, but from my personal experience for severe OA hip, there is mild or even no improvement of 10. Even I saw the angiogenesis around the hip joint, but it's only my own personal experience. For greater trochanteric pain syndrome, it's more work. It's work better. So this is my case, 67-year-old female with persistent inguinal and anterior side pain, right side. And the NIS is 7, and you can see OA of the right hip joint. And you can see some small subchondral cyst and bone marrow lesion over the right femur and the acetabulant. And after nerve block, she say improvement, and then relapse. So I do the ultrasound combined with fluoroscopy guidance, hip joint core. You can see the ultrasound machine and see the fluoroscopy machine. And then I do core IF operation at the osseous acetabulant and the teardrop-like acetabulant using ultrasound to get my target, and then I adjust my needle tip to avoid muscular injury. And she said she is satisfied, and the NIS score dropped from 7 to 1, and there is no relapse observed after 6 months. And this is another case, 66 female, bilateral inguinal and anterior side pain, right side more prominent, and you can see the X-ray, the right side is more severe. And the MRI, you can see subchondral cyst, bone marrow lesion, and the edema at the acetabulant and the femoral head. And I do nerve block, good response but relapse. And then I do bipolar radio frequency operation for her using ultrasound and the fluoroscopy guidance. And then she satisfied, the pain score drop, no relapse till now. So for my personal experience, I will do nerve block first. And if patient choose, I will suggest core IF first, because more larger operation zone. If she cannot afford it because it's expensive, I will choose bipolar radio frequency. And I will use ultrasound combined with fluoroscopy for hip the radio frequency. And thank you for your listening. I am Bow Wang. And yesterday, my twin baby girl come to the world. Yeah, thank you.